I'm on my way to Trinidad. I've stopped at one of my favorite stops called the Mirador, which means the lookout in Spanish. And I've got a topic that I wanted to talk about today, and it's based on a conversation that I had many years ago, probably 11 or 12 years ago now. I spoke to a junior doctor then who will be qualified, he'll be a consultant now for sure, and he was an ophthalmologist in training. And I asked him a question. I said, this is before the Andean Medical Mission even started. My question was, did he feel that we could go into northern Bolivia, into remote villages, and operate safely? And his answer was no. He felt that you needed a big hospital, you needed to have positive airflow systems, you needed to have backup, you needed to have other departments there to assist you, and to have equipment that was big and heavy. And I left a little despondent after that conversation. I spoke to another colleague who was at the other end of his career. He was looking forward to retirement, had been there, done it, travelled and worked abroad as well. And I asked the same question: do you think it's possible to work in a small village in the middle of the Amazon and help people with their vision? And his answer was very different. It was, well, there wasn't an awful lot of eye surgery that he didn't feel you could actually do in the back of a Land Rover. So a different reply altogether. And today I wanted to discuss who's right and who's wrong. So the answer, I suppose, to be kind, is that they're both right. I think the junior doctor had the safety of the patients in mind when he opted for a big hospital as the right solution. And he's right. In a big hospital with everything organized and all the support and backup, of course you're going to do excellent surgery. But I also feel that the other surgeon probably was exaggerating a little about operating in the back of a Land Rover, but there isn't an awful lot that you need in terms of an operating theatre for ophthalmology. You need your patient to be lying down somewhere, you need to have a clean room, you need clean water. There isn't an awful lot more than that you need. So I guess they're both right in their own way. But today I wanted to talk about what is the ideal, what is too small, what is too remote, and what can you get away with is the wrong expression, but what can you do safely that will benefit patients without creating harm? So I'm going to look at that as a subject today. So our starting point really has to be population and how many people are blind. That can be quite difficult to work out in areas where no one has ever been and no one has done an audit or any form of assessment of avoidable blindness. Now, you could go and you could do that yourself, and there is an excellent way of doing this. We're using the London School of Hygiene and Tropical Medicine's rapid assessment of avoidable blindness, but it takes quite a long time to do it, and you're going to need about 5,000 people. You need to interview about 5,000 people in order to get an accurate assessment. You could do it without. If you go to a country that has no ophthalmology services, you go to a rural location, you take a population that's probably dehydrated, maybe people that work in the field, so farming communities, things like that, and there's very little public health, public information. You're probably going to find that 1% of your population at least is blind. In Bolivia, we did both. We did our own assessment, and we used the data that have been published here using the assessment of avoidable blindness, and we came out with almost identical figures. We came out with 3.6% of the population above 50 is blind, and the other study that was done here came out with 3.8 95% of over 50s in Bolivia are blind. So we get a pretty good idea from that, and roughly that's 1%, roughly, if you look at life expectancy and the fact that people have lots of kids and stuff like that, 1%. So you can work out a village of 5,000 people is going to give you 50 cataracts to do. Something like that, and it'll be close, depending of course if other people have been in before you, and of course it depends on your threshold for surgery. If you take ours, for example, the lowest we ever do is sort of 648. Anything better vision than that, we probably just not in a position to do at the moment. We will occasionally do it if someone's a lorry driver or their job depends on it, but largely we're dealing with perception of light, counting fingers, and hand movement vision as the type of cataract that we do. And yes, in a village of 5,000 people, we will find 50 of those, and it's an awful lot of blindness to be tackled. So you can work out, if you're coming to Bolivia or to a village with 1% of the population, then, and you've got a 2-week window to do some surgery, then obviously you're not going to operate on the very last few days, but I imagine if you work hard over the first week and a half, then a population of 5,000 people will give you 50 cataracts to do. It'll give you at least 100 pairs of glasses if you're doing glasses, or more but if you take just the very extreme end of refraction as needing doing. You'll have a couple of kids with squint. You'll have probably 1 or maybe 2 congenital cataracts to do. We'll probably in a village like that have 4 to 10 skin tumors to attend, and if they're on the eyelids, I think that comes under the remit of ophthalmology. And we'll have pterygium. 35% of Bolivians will have a pterygium. Not all of them blind. If you find pterygium on patients that are in their 80s and 90s and they've had them for years and years, you probably don't need to take them off. But in your 40 to 50, 60-year-olds, if they've only had a pterygium for 5 years or less than 5 years, and it's now 4 or 5 millimeters onto the cornea, then yes, that one needs to come off, because that will eventually blind them if you do nothing at all. So you'll come out with somewhere around about 50 to 70 operations that need doing from a population of 5,000. There's no real right way to run cataract services in an area. There's lots of wrong ways perhaps, but finding the right way can be tricky. There's a number of different options that you can look at when you're building services to eliminate avoidable blindness, and obviously cataract being a reversible blindness is something that you are at some point going to focus on, I'm sure. If we take northern Bolivia where we work, we have a geography about twice the size of the UK, and we have 500,000 people in that area. We know that probably 5,000 of those are blind, and there'll be another 5,000 that are at risk of blindness for a number of different reasons. Isn't it? Half are in big cities and half are in really small rural villages, and you split that right down. I mean, you can find villages with just 50 to 100 people in them. They're very isolated. So what is the right way to reach these people? Well, obviously one model would be just to work in the cities. You'll get half the population. That's good. It's a big help. It's easy for people to get to you. You've probably got electricity 24 hours of the day, so you can run long days, long hours, and that would be a great place to start. If you have a big enough city or a big enough town, so say Trinidad or Riberalta, if you start to bring Bolivian ophthalmologists with you, you've got the opportunity to persuade them to carry on when you're not there. That's a really good model to work with. The other model that you could consider is a sort of a hub and spoke type thing where you go into a village, say, with a population of 5,000 people, that's 50 cataract perhaps, and then you go out to 5 or 10 villages nearby and you try and screen people there, and you try and drag them back to your main centre where you're doing all the surgery. The advantage of that model is that you don't have to move. Once you've established your theatre and you've got everything clean and you've got it all just as you like, you're literally just getting as many patients in and through your system as you possibly can. And we've done that, and it does work, but predominantly the patients will be from your village, and that is the really difficult thing in all of this, is people that are blind just don't want to move. Even if you put on a bus, you pay their accommodation and everything else, it's really hard to move them. Even an hour's drive sometimes is just too much for somebody to come. And we've had examples, many examples. One in Remanso, where I went to a village of Capital, 5 minutes away by boat, and a number of patients there that were blind just wouldn't get on a 5-minute boat ride to go to another village. I think they're largely afraid, and I think they just get used to being blind, and it's really hard to move them. So sometimes hub and spoke works, sometimes it doesn't. And then you've got these discussions that are interesting around, what is too small a village? I mean, if you go somewhere with 300 people and you operate on, well, 1% of them is blind, so you operate on 3 people, you do some skin tumours, and you give out some glasses, and you do some education on eye safety, you probably get through all of that in a day, 2 days. Is it worth the trip? Especially if your surgeons are coming from, let's say they're coming from Europe or from the States. So a 2-day, it takes longer to get there than you're actually there for. But there's so many people that live like that, and you have to think, how do you reach them? If you don't, if they live in a small community, well, to reach them you have to go to a small community. And I think for them it's amazing, it's absolutely life-changing. And we've done many villages like that, where you come away and you're thinking, oh, we did 9 operations here, we could have maybe done 9 a day if we'd gone somewhere else, and was it a waste of time? Would we have been better working a big city? And maybe we would have been, but I certainly think for the people that we helped, for them it was amazing, and they were so incredibly grateful. So there's no right way to do it. I think you need to be guided by what you want to achieve, and be guided by things like electricity come into it. Where are you going too remotely? Can you handle the follow-up? I think that's an interesting point. Camps where you go in, operate, fly, take a few photographs and fly away, they don't work very well, I don't think. You need to go back. You will find patients who, a suture has come undone, or some vitreous has moved which you didn't expect, pressures are up. You have to follow up, and you need to be able to get there. So, there are questions around how far is too remote, or how remote is too remote to be effective and to do the right thing. In conclusion then, it's definitely possible to work remotely, and you need to decide what it is you want to achieve, who you want to achieve that for, and then, yes, definitely go out there and do it. There will be challenges. You may have to do 2 or 3 trips until you get the confidence of the population that you're working with. But if you do good surgery, you will gain that confidence ultimately. If you've enjoyed today's episode, I'll be covering equipment next week, and mainly for clinic, and then the following video I think will probably be on how to set up or how we set up an operating theatre in terms of getting it clean and the equipment that you need to safely operate. So look out for those, subscribe to the series, and I'll see you on the next one.